Good morning. Welcome and thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. The pandemic is still highly active. High hospitalization rates, deaths, public indoor masking, young people getting very ill, boosters, mandates. The list is long and changing rapidly. Our goal is to provide you with reliable, up-to-date information to assist you to understand and manage. Today, our topics will include latest on COVID-19, boosters, vaccines and mandates, monoclonal antibodies, supporting our mental health. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Beacon Health. I'll be your moderator for the next hour. Our panelists today are Dr. Kyle Massey, Co-Director of the Antimicrobial Stewardship Program and Clinical Pharmacist with Infectious Diseases expertise at Northern Light Eastern Maine Medical Center. Noah Lundy, Vice President of Human Resources, Northern Light Health. Angela Felicia, Director of Healthy Life Resources Program at Northern Light Acadia Hospital. Dr. Jim Jarvis, Director of Clinical Education at Northern Light Eastern Maine Medical Center and Physician Leader for Vaccinations and COVID-19 Incident Command at Northern Light Health. Before we get started, I will read our legal disclosure. The coronavirus pandemic is an ongoing, continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. Northern Light Health does not know the particulars of your situation, so the information presented today is general in nature and is based upon Northern Light Health's own experience, which may or may not apply in your specific situation, and which may be revised as we learn more about the coronavirus. Accordingly, following any guidance Northern Light Health presents today in no way guarantees that you, your employees, and/or your customers and clients will not contract or spread the coronavirus. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with a COVID-19 update. Jim?
Thank you, Ed. So we'll start by going over some of the numbers that we've been seeing across Northern Light Health. On the left, you'll see our testing results. And you can see that trend line tends to be going down, which sounds wonderful, except it is still exceedingly high. If we look at our positivity rate over the last 2 weeks, it is now 10.12%. And that total really represents the total number of positive tests divided by all the tests that we run at our laboratory. Not all of those are done for Northern Light entities. Sometimes we have other providers and other entities and hospitals that request of us to run tests. So it is a very good snapshot of what's going on out in our communities. 10%, we used to talk about 1% positivity rate, meaning it would tell us that there was a significant amount of community spread. This 10% means that 1 in every 10 tests that we run is a positive case, and that is a very high number, and indicates that not only do we have community spread, but it is really across everything. I've been asked, well, is that just simply a matter of how many tests you're running? Well, actually, we're running more tests now than we ever had during the pandemic. On many days, we are exceeding 1,400 tests a day. And so, yes, this is a very good snapshot to show us that while the numbers may be improving, they're only improving slightly, and that community spread is very high. The graphic to the right actually shows us what we're seeing across our hospital systems. And again, it is a snapshot in time. And this slide happens to be from 2 days ago. And so it doesn't represent current numbers, but it is a good representation of what we're seeing in our hospitals. At the time when this data collection occurred, 77 patients were in our hospitals across Northern Light Health. Of those, 51% were unvaccinated, or 51 were unvaccinated, and 26 were vaccinated. If we then look at how many patients are in our intensive care units at that time, there were 31, again, with a very large percentage of them being unvaccinated. And then similarly, when we talk about the highest risk, those that were vaccinated, or those that are on ventilators, again, we see those numbers again where it's heavily shifted towards vaccinated. I've had people say, oh, well, doesn't this say that the vaccines aren't working? And actually, it shows the opposite, because when we talk about vaccinated in this slide, we're actually talking about people who have received the full dose of the vaccine and waited 2 weeks, but also those that have had just one dose of either the Pfizer or Moderna, or their single dose of Johnson & Johnson, and the 2-week waiting period has not yet eclipsed. So that vaccinated category actually contains people who are not fully vaccinated. Also, in the state of Maine, the majority of people in our state are vaccinated. And so they're the largest pool that we would see getting infected, and yet we're not seeing that. We're seeing that smaller pool of unvaccinated individuals who are being hospitalized, particularly in our critical care units. So next slide, please. So that kind of takes us into vaccines and boosters and where are we right now. Boosters are certainly a big topic out in the media. Right now, the FDA and the CDC do not recommend COVID-19 booster shots for most people who are over the age of 12. The most important thing we can do now to stop the serious illness of COVID-19 is ensure that every eligible person completes their initial vaccine series. For those where booster shots may be appropriate, they are only authorized for those who have finished the Pfizer vaccine series at least 6 months ago. The FDA and the CDC are reviewing data from Moderna and Johnson & Johnson vaccines, and we expect that we will hear about the Moderna vaccine and whether or not there's booster recommendations for certain individuals by the end of this month. Johnson & Johnson may take a couple of months longer because they've always been a little bit behind in that process. Next slide, please. So who should be getting booster vaccines? Well, those, and again, this is only for people who received Pfizer initially, people 65 and older and residents of long-term care facilities, people who are age 50 to 64 who have underlying medical conditions. And I've had a list there, and of course, we'll share those slides with you a little bit later so you can kind of look in that. That is not a complete list, but certainly those are probably the largest majority that would affect people here in Maine. Next slide, please. So who may receive a booster shot? Well, those 18 to 49 years old with underlying medical conditions, so again, not in that same age category that we just spoke about, and then people 18 to 64 who are increased risk of COVID-19 exposure or transmission due to an occupational or institutional setting. And those high-risk occupations are first responders, including healthcare workers, firefighters, police, and those who live in a congregate living situation, teachers and support staff, daycare workers, food and agricultural workers, manufacturing workers, correction workers, U.S. Postal Service workers, public transit workers, and then grocery store workers. And that's because each of these individuals either come in contact with multiple people in the public on a regular basis as part of their work, or they are working in a situation where some of those other high-risk categories that we spoke about before congregate. So next slide, please. Well, what about kids? Where are we with them? So currently, there is still no vaccine authorized for children under the age of 12. Pfizer has submitted data for review to the FDA and the CDC for them to review the data on lowering that age at least to the age of 5. We are hopeful that we will hear more information and have recommendations either for or against vaccinating children under the age of 12 by Halloween. That is the goal that Pfizer has set. Obviously, the FDA and the CDC will do what they need to. I will point out that the FDA and CDC released a joint statement that they will do their due diligence in reviewing any vaccine requests for children. So that's a twofold sword there, right? We want them to do their due diligence because we want to make sure the data is accurate so that we are giving something that not only is safe but effective for our children, but at the same time, that takes time for them to do that. And so it may take a little bit longer than many of us would like in order to get our children vaccinated against COVID-19. And with that, I'll turn it back over to Ed.
So Jim, I have a question that has come up that I think it's just pertinent to actually ask now before we move on. So here's the question. If Pfizer is the only one approved for boosters, does that mean it is less effective than the other two?
Yeah, that's a great question, Ed. And so we don't think that's the case at all. And I want to be clear, for those of us who received either Pfizer or Moderna or even Johnson & Johnson 8 months ago, we feel that those vaccines continue to provide adequate protection for us against both hospitalizations and severe disease, but more importantly for death. There may be some increased transmission rates between people who had those vaccines so long ago as we see immunity wane, but we still have incredible immunity to this coronavirus. In fact, it exceeds what most other vaccines provide for us that we just consider a normal response for an immunologic response to a vaccine. The only reason why Pfizer is ahead of the Moderna and Johnson & Johnson is simply because we've had the Pfizer product longer and they have more data, and so we're able to submit their data sooner. It's the reason why Johnson & Johnson has always lagged behind, because they were a little bit behind in the development of their vaccine, and their studies are behind the other two.
Okay, so don't overread the timing, huh?
I would not overread the timing at all. I know there's also questions about whether we can mix and match vaccines, and at this time in the United States, that is not recommended. We do know that there are other countries in the world where they have mixed and matched vaccines. We do not anticipate that the United States will be doing that in any grand scale, though.
Okay, well, thank you, Jim. Next up is Dr. Massey, who will help us understand the role of monoclonal antibodies. Kyle?
Thank you, Dr. Gilkey. So I just wanted to start by trying to demystify these kind of long and intimidating names attached to monoclonal antibodies, which we also refer to as MABs for short, and I may be doing that several times throughout the rest of my piece here. Unfortunately, only one of these has a trade name attached to it, and so the rest we're kind of stuck with these scientific names. But something that many may not know is that monoclonal antibodies follow a pretty specific naming convention, and so you can find commonalities among them. So the three authorized MABs are bamlanivimab and etesivimab, casirivimab and imdevimab, and then sotrovimab. Two of them are combination products, and sotrovimab is a single monoclonal antibody. The first part of these names is a unique identifier used only for that specific molecule, but the second part, the VMAB, is actually broken into two pieces, the V denoting its purpose as targeting viruses and the MAB identifying it as a monoclonal antibody. So if you recognize that the VMAB is the same on all of these, it's just a matter of remembering those shorter pieces, Bamlani, Edesi, Kasiri, MD, and Sotro. Man, I make things a whole lot better, but yeah, it makes it a little bit more digestible. Next slide, please. Okay, so antibodies are part of your immune system's response to infections, including infections from viruses. They're often represented in graphics as this kind of Y-shaped molecule. And each one has a very unique shape that allows it to stick to very specific parts of the virus, essentially like a lock and a key. When exposed to a new virus, your body spends about 1 to 2 weeks creating antibodies that perfectly fit different parts of that virus. When the immune system creates these many antibodies, we call those polyclonal antibodies, poly meaning many. To create these therapeutic antibodies that we're using for COVID-19, scientists isolated from these many antibodies one single antibody that provides the greatest viral neutralizing capability or ability to fight the virus. Because these therapeutics only contain a single type of antibody, we call them monoclonal antibodies, mono meaning one. These antibodies work by sticking to parts of the spike protein on the virus, which is an important part of the virus's ability to attach to our cells and infect them. It's important to understand also that as we're using these now, the main intention of these monoclonal antibodies is not necessarily to cure COVID-19, but rather helps to prevent worsening to severe disease, similar to the way the vaccines work. Next slide, please. As mentioned before, it takes about 1 to 2 weeks for our immune system to create its own antibodies to target the SARS virus. This chart on the right shows the quantity of virus and antibodies present in patients infected with SARS-CoV-2 over time, and the scale there is in weeks. And as that line gets higher, it's more antibody or more virus present. Upon infection, the quantity of virus rapidly grows during the first week, and at this point, our body starts to produce its own antibodies to fight the virus. And the quantity of virus starts to decline pretty rapidly thereafter. Now, the graph represents an average, and many patients, particularly those at risk for severe disease, can take much longer for the immune system to react, therefore allowing the virus to spread to a greater degree and cause more tissue damage. And this ultimately leads to severe COVID-19. Now, MABs essentially act as a bridge, helping our body fight the virus while our immune system works on creating its own antibodies. Now, in vaccinated patients, also, this timeline is significantly reduced, meaning our body can start ramping up antibody production within a couple of days, as opposed to 1 to 2 weeks after being exposed to the virus. And this is why, even in the setting of breakthrough cases of COVID-19, vaccinated patients rarely progress to severe disease. Next slide, please. Now, the MABs have been studied in 3 randomized controlled trials, which are the gold standard of trials for therapeutics. And they looked at about 2,900 patients who received the antibodies and compared them to an equal proportion of patients who were given placebo. The bars in the graph on the right represent the percent of patients in each trial that progressed to hospitalization or death in the placebo, which is the lighter green bar, in treatment, which is the darker green bar, arms. And you can see that the results are fairly similar across all 3 products, with between 4 and 7% of patients in the placebo group being hospitalized or dying, and 1 to 2% in the treatment arm. This overall equates to about a 70 to 80% reduction in the risk of these outcomes, which isn't quite as high as the benefit you receive from vaccination, but it's still a very effective therapeutic. Based on these data, the MABs have received FDA authorization for use in patients 12 years of age or older with risk factors for progression to severe COVID-19. Next slide, please. So to visually represent this from a population standpoint, imagine this slide represents 100 high-risk Mainers who are infected with COVID-19. Can you click next? Based on the trial data, go back one. Based on the trial data, we would anticipate that 7 of them may progress to severe disease and 2 may ultimately die. Okay, now please click to the next. If we were able to administer MABs to all of these patients, we would anticipate that it would reduce the number of severe COVID-19 cases by 5 and potentially 0 deaths. This would not only have a significant impact for these patients, but also plays a critical role in reducing the strain on our hospital systems in the setting of surging cases. Next slide, please. So at Northern Light, we've rolled out a streamlined process to facilitate greater public access to the monoclonal antibodies and increase our capacity to administer these. We now have algorithms built into our electronic health record to identify patients who test positive for COVID-19 within the Northern Light Health System and are at high risk for severe COVID based on comorbidities and other factors. This information is then routed to a central team who evaluates each patient for eligibility per the FDA authorization criteria, and then contacts these patients to let them know, 1, that they're eligible, answer questions that they may have, and then help schedule them for an infusion at one of our infusion centers located across the state. The patient's PCP, primary care provider, is also alerted to the patient's eligibility, and patients may choose to opt out of the process ahead of time in discussion with their PCP if they so choose. Next slide, please. Thank you. So to summarize, and to also add one last little plug for vaccination, MABs and vaccines provide antibodies against the virus and have a very similar role in protecting patients from developing severe disease, being hospitalized, and dying. And while all of the vaccines and MABs have received authorization for use from the FDA, the vaccines are only product that have received full approval to date for many of the reasons that Dr. Jarvis already explained, including timing and the amount of information they have to submit. And specifically, the Pfizer-BioNTech has received that FDA approval. Both have been studied in multiple trials, but where they differ significantly is, 1, in the ease of administration. MABs require a 1-hour infusion at an infusion clinic versus a few seconds to administer the vaccine at any of your local pharmacies or vaccine clinics. And for supply, we currently have a very limited supply of the MABs, but we do have plenty of vaccines. So the best option available to us for preventing severe COVID-19, hospitalization, and death, both for yourself and for the public, is vaccination. But MABs are an effective therapeutic, particularly for those who are unable to be vaccinated. And with that, I'll turn it back over to Dr. Gilkey. Thank you very much.
So thanks, Kyle. I'm going to actually throw a question at you too that's real time. So please feel free to go back on video for a moment. How available are the monoclonal antibodies is the question. And I think you just touched on that towards the end of your presentation, but maybe you should point that out a little bit more.
Yeah, sure. So we have a limited supply. It's currently being controlled by the federal government, who is allocating supply across the US based on local needs and surges within states. So the amount of drug that we have available is limited by the distribution that's sent to the state. Our state receives it, and then we distribute it to the hospitals and infusion clinics who are seeing patients and infusing these. Now, we don't have enough currently for every single patient who contracts COVID-19. And so from the list of criteria that we have out there, we really try to make sure that we get these out to the highest risk and most vulnerable patients. But unfortunately, in the case of a surging pandemic, if we have thousands and thousands of new cases on a daily basis, we simply won't have enough MABs to treat every single patient. And so again, plugging vaccinations, this is why vaccines are so important, because they're going to give you that same protection and you can get it now rather than waiting to be infected.
So Kyle, a good source of information, if somebody thought that they would be eligible for monoclonal antibodies, would be their primary care physicians or providers?
Correct. Especially within the Northern Light Health System, our primary care clinics and providers are tuned to this process that we've developed. And if you think you may be eligible and you haven't yet been reached out to by our team, which should be reaching out to you within a day, within 24 hours, you can contact your PCP as well to discuss with them, and they can certainly initiate the process.
Well, thanks so much for that information, Kyle.
Absolutely.
Next is Noah Lundy, who will speak about vaccine mandates. Noah?
Good morning. Thank you, Dr. Gilkey. So I wanted to start with just really a broad brush, I guess, approach to some of the vaccination mandates that have taken over the news as of recent. And probably the biggest splash was President Biden came out with an executive order requiring all federal employees and contracted workers to be vaccinated. And this actually is also going to include any employer that has 100 or more workers as well within the U.S. And so the administration has outlined that the 100 or more mark, if you will, is a total aggregate of employees. So certainly, a facility might have different satellite locations with, 10, 15, 20 employees. But if that total adds up to the 100 or more, they're going to fall under this mandate. And that is to be fully vaccinated by November 22nd of this year. So they've actually tucked this mandate under OSHA, which is the Occupational Safety and Health Administration. And it's really the arm within the federal government that guarantees workers to have, a safe work environment. And certainly OSHA, many of you I'm sure have heard of, if there's a workplace accident or that kind of a thing, might get engaged as well. So this is, again, a big part on the administration to mandate folks get vaccinated. Some of those details, again, are still being hashed out, and I haven't seen a lot of specifics as far as how they're going to track what organizations are following this as far as the federal mandate. So certainly more to come on that, but I just wanted to, again, give a broad brush update to this podcast around that. Likewise, the state of Maine has come out a few weeks back, or well over a few months, I guess now, in mandating healthcare workers are required to be fully vaccinated. So again, that's 14 days after their second dose, if it's a 2-dose vaccination, or 14 days after the 1-dose J&J. And so that deadline again is the 29th. So that's coming very quick. And so certainly Northern Light Health is going to be abiding by that state law for sure. And so if we can go to the next slide, I kind of want to talk about some of the effects on Northern Light Health, I guess, and also what we've done as an organization to really help support our employees to reach this goal. So what we've done is, really obviously trying to take a very employee-centric view. We have a lot of resources, whether it's providers or pharmacists. So if our staff have questions or concerns, really being able to, provide them with either one-on-one consultation or have that conversation around the vaccines or any concerns that they might have. Medical exemptions is also another avenue that an employee can request if they have or feel they have a medical exemption as to why they wouldn't be eligible to get the vaccine. That's certainly an avenue, again, that we've taken as an organization to provide for folks. Currently, right now, as of Monday, data, and this will get updated at the end of this week, but Northern Light as a whole is at just under 93% of vaccinated workforce. So again, we still have some work to do, but we're confident that we'll continue to see this number uptick in the weeks to come. And the staffing impact as far as folks leaving, we've actually seen 89 employees leave as a system, again, total But this was actually prior to when the state announced that the flu vaccine would be mandated for healthcare workers as well this year. So again, 89 is certainly losing any employee provides an impact, and we don't want to see employees leave. But again, on a whole, 89, given our workforce size, isn't huge. If I can have the next slide. So tools that your organization might be interested in. So I know that the Northern Light website, general website, has a lot of information around COVID-19 information, has things like if you're eligible for your booster shot that I know was talked about a little bit to start, but also just other general guidelines and information and links that might, again, be useful to you all as employers or folks in the public. Certainly the CDC and the Maine CDC has a very robust website that will provide information for, again, either employee focused, employer focused, or for employees or individuals. So would encourage you all to check out those sites. There's, again, on our Northern Light website, the ability to look to get vaccinated or a link to set up time to do that. Other tools that some organizations have set up are things like masking requirements and the like. And we certainly know from a safety perspective that the masks really do work. And if I could get the next slide, thank you. So again, one of the biggest things from an employer standpoint is communication, I think. And one of the great things I think we've done as an organization is being able to really clearly articulate and communicate with our staff. And so some of this is done via, general email. We hold a weekly town hall forum, which has been very useful for our staff to be able to come and hear updates. All things COVID, certainly it seems like it changes by the hour or the minute. So I think that's been very useful to make sure that all of our employees have very timely information on either requirements or changes that are coming down the pike. Certainly, we have an internal intranet page, which again, we post a number of different links and information for our employees that just at a click of a button can be informed or be able to fill out, a form that they might need or provide information. So, I would encourage you all certainly to be able to just make sure it's a two-way street, but you want to be able to push out as much communication in as many modalities as possible to make sure that folks are getting the correct information and not having to search for it. And then another way for employees also to become informed is I know the CDC and 211 have partnered with a hotline as well. And so I'll put that information here for folks.
Well, thanks, Noah. I have a question in real time for you as well, as it turns out.
Sure.
Do volunteers in an organization count towards the 100 or more employees? Great question.
As far as the 100 or more, you're talking about for the federal?
Yeah, so the federal is 100 employees or more, but if you have a lot of volunteers coming and going, do they count as well? That's an interesting question.
Yeah, the very interesting question. Again, I know that some of the finite details as it relates to the Fed regs haven't been sent out yet, but I would so I'll take a educated guess and say, anybody that represents your organization, given that federal deadline, would need to be vaccinated. But again, I don't have the specific answer to that as it relates to the regs.
Yeah, I kind of reinforce that. If you think, 100's probably a relatively arbitrary cutoff that they developed for some reason, but the idea is, managing exposure. So the answer probably is yes, I would agree too. And, but more to follow as we learn further clarification on that. So thanks, Noah.
You're welcome.
Next is Angela Felicia, who will speak about stress and strategies to reduce it. Angela.
Thanks, Dr. Gilkey. I'm always happy to be a participant in these really informative webinars. I've learned something yet again already, so thank you all. Obviously, given what we continue to talk about, the pandemic, the surge, vaccine mandates, paying attention to our mental health and wellness continues to be more important than ever before. I think it's really helpful to think about sort of where we are in context of this crisis cycle. Obviously, we've been under this chronic sort of state of crisis, disaster, if you will, for some 20 months now. And you can see from this graph of the crisis cycle, right? A typical crisis is really short term. You sort of have that peak, and then phew, you get to breathe that sigh of relief and recover, de-escalate, sort of come back to normal. We haven't really had that opportunity to do that. So we're kind of constantly back in that agitation phase where we might be feeling irritable, cranky, frustrated, maybe not sleeping well, etc. It can really take a toll on our mental health. Next slide. And because of that toll it takes, we really want to pay attention to some pretty common signs and symptoms of reactions to stress. This is not an exhaustive list, but these are pretty common signs and symptoms. It can be really helpful to recognize what your own signs and symptoms of stress are, and then also helpful to recognize what some of these common signs are so that you can recognize them in friends, coworkers, loved ones. I share with folks that really a real common sign for me, it falls under that cognitive or thinking sign where I just don't seem to have my memory up to par. I sort of forget basic things, forget words, etc. That can be seen in the workplace fairly commonly in times of stress and difficulty. So really paying attention to some of these signs is critical. Next slide. And then, of course, it is back to school, right? So we're at the end of September. Kiddos have been in school for a month or perhaps coming up to a month. It's also important to really think about and pay attention to what are some of those signs and symptoms we might see in youth or even younger children. Obviously, children and youth can exhibit some of those same signs and symptoms on the previous slide. However, sometimes they exhibit some different ones as well. Adolescents in particular might experience an increase in restlessness or agitation or frustration, just inability to sort of get things done. You might even hear from adolescents that they feel sick, right? My belly hurts, my head hurts, I don't feel well. Certainly that could be an illness, but it also could be a stress reaction. In younger children, you really want to look for things such as a regression in behaviors that kiddos have used to be completely fine with. Bedwetting, for example, or even potty training can regress backwards. Sleeplessness or nightmares, that can certainly happen in younger children too, and things to be really on the lookout for. Next slide. So once we notice signs and symptoms, we want to be able to help ourselves. We want to be able to help others. This is a really long, stressful time period we've all been under. So it's really important to create rituals, both in family, home life, but also in your work life, that really help shore people up, that create resiliency, that can help decrease some of those stress responses. These are just a handful of ideas. Really anything that sort of brings comfort to you, your family, your coworkers could be an everyday ritual. Many of us, if you're like me, you like to enjoy coffee in the morning, right? So maybe turn your daily coffee into a ritual where you get a really nice mug so that you can really have some enjoyment. So it can be something small like that that can give you that little bit of sense of comfort, so that we're thinking about creating comfort in our day in these little micro ways to sort of help us mitigate some of those stress responses. Next. And then just some additional strategies that can be really helpful. Certainly, these are strategies for parents and caregivers for kiddos, but this can absolutely be strategies for all of us. Being mindful of screen time, you'll see on there. I'm a remote worker. It's really important that in my off time, I don't hop on another screen to look at social media, right? So that I give myself a break from screens. For kiddos in particular, you want to keep routines as predictable as possible, even if the context or the climate is really unpredictable, right? So we might not know if a school is going remote. However, you can talk with kiddos, you can talk with adolescents ahead of time to say, gosh, if your school does go remote, here's how we're going to manage that. Here's what we're going to do. That kind of predictability, the talking about it can give that sense of control and can be really helpful for folks. And next, I think we're back to Dr. Gilkey.
Great. Well, thanks, Angela.
Thank you.
So for this next segment, we will ask our panelists to join on video and to answer your questions. Just a reminder to place your questions in the Q&A box. So I'm going to start off a series of questions, Kyle, with some questions about monoclonal antibodies. So the first one is, do the monoclonal antibodies have a shelf life?
They do. So there are expiration dates on the monoclonal antibodies. Off the top of my head, I couldn't tell you exactly what they are. What we'll find with these, as with the Pfizer vaccine and the Moderna vaccines, is that for a lot of these, the total time to evaluate shelf life was limited during the initial trials for approval. So we'll likely continue to see updates on expiration dating for many of the products. For the monoclonal antibodies, the functional shelf life currently is maybe a couple days, in that we're using them pretty much as quickly as they can come in.
So nothing's going to expire before the demand is there, correct?
Correct.
Okay, great. A couple more. Which MABs are being used at Northern Light Health?
So currently we're using bamlanivimab and etesivimab and casirivimab and imdevimab, which is the only one with the trade name REGEN-COV. Those are the two antibodies that we keep that we receive from the federal government. We also are able to use sotrovimab, but at this time we haven't employed that in practice yet, but we'll look to turn to that should we need to increase our supply.
Great. You make it sound so easy to say those words.
Get a lot of practice.
I bet. Are these MABs for both vaccinated and unvaccinated patients?
Correct. So the emergency use authorization doesn't exclude vaccinated patients from receiving monoclonal antibodies. That said, as we continue to evaluate as a state the criteria that we're employing for use of these in a setting of limited supply and surging demand, the theoretical and known benefit in vaccinated patients may move them to different areas in a prioritization chart. I don't think that should be taken as a the reason that that vaccination shouldn't be targeted with the monoclonal antibodies. Important thing to understand is that the vaccination in the first place is far more effective in preventing than trying to get the monoclonal antibodies infused. But at this time, they're not prevented from receiving it, but they are in a lower risk group on the basis of being vaccinated. One caveat there is patients who may not be able to mount an adequate immune response to the initial vaccination. And we know who a lot of those groups are. They're patients with baseline immunosuppression. And in those groups, we would continue to treat them as if they were unvaccinated should they need monoclonal antibodies.
Awesome. So Kyle, I think I heard you say in the course of your presentation and reinforced along the way, we have an abundance of vaccinations available. We have a limited supply controlled by the federal government via the state government for monoclonal antibodies for treatment. Therefore, our best strategy is vaccinations at this time. Did I interpret that correctly?
I think you got that 100% nail on the head. The vaccinations are available. They take 5 seconds and they're very effective.
Great.
It's the best opportunity we have.
Great. I have one more that's actually not a question you're going to answer, but can you direct me to information on how monoclonal antibodies are created? So I don't know if it would be useful to type that out or something, if you have some way to connect somebody to the science behind it, which is great. Okay, well, thanks, Kyle. The next series of questions I'm going to ask Dr. Jarvis. Our organization works with immunocompromised patients. Based on your information, would our staff be eligible for the Pfizer booster?
So probably not unless they met one of those individual categories. It's really staff who are working with those individuals in a congregate living situation, such as a long-term care facility or a group home or something along those lines. But certainly you can go to the CDC website to see if your particular organization meets one of those categories.
Great, thanks. Jim, I have another question here that I think you answered in the chat, but I'm not so sure that everyone got to see it. So, feel free to read your answer if it's available to you. Since the vaccinated category of people in the ICUs and on ventilators has slowly increased, does that not point to the need for boosters? If any of those people that are vaccinated are in the ICUs or on vents are not in the current categories for the booster, does this not give evidence for the need to have across the board booster for 18 and above? So there's two questions there.
Yeah, and I think I can answer them together. And that's an excellent question and something that we ponder with, and it's certainly what the questions that federal authorities look at when they're trying to determine whether or not to advise booster shots. And the answer is while it's not universal, most of the vaccinated individuals who are hospitalized with symptoms from COVID have some other compromising or comorbid condition. So they fit into a high-risk category. And that's even more expressed when we look at those that are in the ICU. Those that are vaccinated in the ICU tend to already have a condition that puts them in a situation where COVID-19 is typically a more serious disease. And so really what it's showing us is that, it kind of lends to the fact that those individuals probably would classify as a recommendation for booster shots, and that those who are otherwise healthy, who are fully vaccinated at this time, do not necessarily need a booster shot.
Excellent, thank you. Noah, I have a couple of questions for you. The first one is, you touched upon this just a little, but this might be an opportunity to really clarify about staffing across the state and availability. Like, for instance, we know there, as of yesterday, there were 41 critical care beds available in the state, according to Dr. Shah, so very limited supply. What impact on care will this mandate have on patient care when you are already short-staffed? So you mentioned the 89, but I think they're interested in a little bit more detail there.
Sure, great question. So again, we're certainly focusing on educating our staff and getting to that 100% threshold per the state law. We know right now certainly travelers and other healthcare workers to bring into the organization are very limited as well throughout the country. But so we've certainly been working with our clinical leaders and other leaders within the health facilities to come up with contingency plans. If we anticipate some kind of a staffing, to be short a staff. But as far as patient care, as an organization, we're certainly committed to continue to provide that great patient care. And so we're putting in, like I said, plans around that, but don't anticipate that any of this will impact patient care.
Great, thanks. So I'm going to read you this question, and certainly others can weigh in. We'll start with you, Noah, from your perspective. During the public hearing the other day concerning the governor's mandate, we heard from nurses and EMTs and one scientist who opposed the vaccinations. I do not recall hearing any doctors testifying in opposition. Where is the disconnect? How do those of us in support of healthcare, residential settings, for instance, counteract anti-vaccine sentiment when licensed medical professionals are suggesting that they are unsafe. The Mills mandate eliminates the religious exemption, but the federal mandate may still have that exemption. We do not know. So there's three components there. First is the disconnect, since there's not doctors that are coming out in opposition. And then secondly, how do we actually communicate to folks that have the anti-vaccine sentiment? So a couple things there.
Yeah, so again, we're certainly communicating with our employees, and that's one of the reasons, again, I talked about offering up one-on-one consultations or other avenues for employees to get questions answered, but really putting them in contact with our medical providers and pharmacists who have the specific scientific information. And I'm sure Dr. Jarvis could elaborate on that, but we want to make sure that employees are getting correct information and being able to make a decision based on correct information. There is a lot floating around, certainly online and in different chat areas. So I think it's very important as an employer to be able to put our best foot forward to educate folks around that.
Mm-hmm. And I'll just add to that at that particular hearing, Northern Light Health certainly did provide testimony on behalf of our employees, providers, and staff. So that's a huge number of individuals. The Maine Medical Association similarly did. The Maine Hospital Association submitted a written statement, so that was not read out in the public forum. And as did just about every major group that represents physicians across our state. So to be clear, the overwhelming majority of physicians and nurses support this decision and support vaccination. I'll just counter that with the fact that right now it is estimated that 65% of all misinformation out there about vaccinations come from just 12 individuals, and that those 12 individuals are repeated over and over and over again. Those of us that remember the commercial that talked about, Trident is recommended by 4 out of 5 dentists who recommend chewing to their patients who chew gum. No one ever asked what that 5th dentist recommended. In this case, 12 individuals are recommending against vaccination, while millions of physicians, scientists, and researchers are recommending for vaccination. Let's listen to the millions, and let's drown out those 12 individuals.
Yeah, I'll put my 2 cents on this too. I spend a great deal of time. I'll give you an example of speaking to one of our staff nurses. The question that was raised to me is, Dr. Gilkey, I've done a lot of research on my own, and I conclude that the data reporting in the United States on COVID-19 deaths is inaccurate. They're calling everything where people die and end up having a positive COVID test as a COVID-19 death. So my response to that was first to recognize that we're not comparing apples to apples in the data being collected around the world. I think China has given lots of evidence that they're inaccurately and underreporting deaths due to COVID. I think data coming out of Russia has always been suspect in every way for all of us. And then what I said to her that I think made a difference in her understanding was, I agree we should do the research and we should understand the data, but there actually is a more comprehensive data set to consider. So if we concluded that everything that could be related to COVID-19 is counted in the United States of America as a COVID death, then we have to look at the overall data from 2019 compared to 2020. If we assume that 330 million people lived in the country in both 19 and 20, and that's a reasonably safe assumption, then it's interesting to note that there was an excess of deaths in 2020 over 2019. And those excess deaths actually happened to mirror the number of people attributed to deaths for COVID-19. So while, yes, somebody who had a heart attack while testing positive for COVID-19 may have been counted as a COVID-19 death, if we look at the overall statistical analysis, those excess deaths were enough to actually decrease the life expectancy of Americans as of 2020. So this is an exceedingly important set of mortality data. And I think with that more comprehensive understanding of the data set, that nurse actually eventually she did choose to get vaccinated. So I think that's where the answer to this question really takes flight and becomes real. And I'll share with all our audience, you have easy access to our prior sessions on this, the same place that you registered for this current one. And I'll draw your attention to May 6th, June 3rd, and June 17th. Each one of those, we covered various aspects of vaccine hesitancy. And I think you just have a treasure trove of opportunity. Each one is an hour long like this is, but you can pick and choose out of that. And there's great information there for you to use to try to address people's concerns. So I'll keep moving along here. Thanks everyone for those answers. The next question is for Angela. Are the stress reduction strategies different now that we are dealing with a prolonged pandemic?
That's a great question. Stress reduction strategies, particularly because of how long the stressor has been, are more critical now than ever before. You know, we might in fact be really feeling sort of that weight of this chronic tension, the conflicts in regards to vaccine mandates, maybe even having interactions with coworkers, peers, family members who have some anti-vaccine thoughts can also cause stress. So now more than ever, making sure that we're doing things to really take care of ourselves on a daily basis is critical.
Excellent. Well, thank you. I'll draw your attention. Dr. Massey has put a great article referenced in the chat room regarding how monoclonal antibodies are created. If for some reason you're not able to see that, draw my attention to it in the Q&A, and then we'll address that in multiple ways. Okay, let's see. The next question actually is for you, Kyle. Are there risks associated with monoclonal antibodies?
Sorry, yes, so as with every medication, there's always going to be risks associated with receiving it. For the monoclonal antibodies, they have been so far shown to be very well tolerated in the studies. The types of reactions that patients experience are expected typical reactions with many infusions, including temporary itching, increased heart rate, fainting, and redness at the site of injection. And for most of these, they weren't significantly greater than placebo. Serious allergic reactions like anaphylaxis have been extremely rare, but have been reported. There is also the need to travel to the infusion centers, and the overall infusion time is about 3 hours. So there is some planning that's going to be involved with it as well. And of course, since those receiving the infusion will be actively infected with SARS-CoV-2, infection prevention practices like masking, social distancing, and hygiene are particularly important to protect yourselves, other patients, and staff.
Excellent, thank you. Noah, this question is for you. I have less than 100 employees. Do I have the ability to mandate them to get vaccinated or terminate their employment?
So an employer can certainly mandate employees getting the vaccination. So that's certainly an option for employers. You know, again, I'm not certainly going to give legal advice, but we need certainly to give the ability for to request an exemption, as I spoke about earlier as well. But, you know, an employer does have the right, you know, certainly to to provide a safe work environment for all employees. And so if that's part of your policy and or procedures for a safe work environment, then that's something you could certainly explore.
Great, thank you. Jim, a question for you. What is the situation in Maine with new cases, hospitalizations? I guess going beyond the data is a way to put this. How bad is it from an insider's view?
Yeah, unfortunately, it is bad, Ed. We continue to see more cases. I won't say they're increasing now because we may have hit that plateau, but when you're hitting a plateau with higher numbers than you've seen at any other time during the pandemic, that is not good news. We are hopeful that we will see a decrease coming up in the next few weeks because we have seen that in other parts of the country. But as we've talked about before, particularly with respiratory viruses, Maine usually lags behind the rest of the country. And we do know there are continued hotspots around the country, which Maine could continue to be one as well. As far as hospitalizations go, that's always a tricky kind of number for us. So hospitalizations, when we talk about that, those are people who are acutely being treated for COVID-19 symptoms. We often have people who get better in our hospitals, but unfortunately are not ready to return home. And so they continue to take up a hospital bed, even though they're no longer sick with COVID-19. And that's where we're seeing our biggest backlog right now. The reason why our hospitals are full is twofold. One, because we have people who are coming in with COVID-19 who we would not have expected at any other time because we didn't have that as a disease for. And then those who have recovered from either COVID-19 or other conditions, we no longer have the ability to send them to long-term care facilities or skilled nursing facilities like we used to because we just don't have those beds because those beds are also full. And so it's an input issue, it's a backlog issue, and it's concerning because we want to continue to be able to take care of those people who have heart attacks, are in car accidents, women who are going to deliver babies who are sick. We want to continue to do those things, but we're making it awfully hard on ourselves when we continue to have people coming in acutely ill with COVID-19.
So another reason to vaccinate.
Absolutely. It's protecting yourselves in multiple ways, right? Protecting yourselves from getting the virus, but also protecting you so that if you have a need as a community, if we all do what we should do, we protect each other.
Quick question for Angela. How do I engage my staff to talk about stress reduction strategies? I think we need to agree we have problems. Am I overstepping as a small employer?
That's a great question. Absolutely not overstepping. Inquiring how people are doing, being a real live human with your coworkers is critically important. And most of the time people appreciate that. You can actually do that kind of check-in at each and every staff meeting. You can have a special town hall. We've certainly done that here at Northern Light Health, but really checking in with people, asking how they're doing, asking, gosh, what ways can we help decrease your stress? That's going to be the hallmark really of a good employer.
Great, thanks. So another quick question here. Can you get COVID and flu at the same time? So Dr. Jarvis, could you comment on that both from the primary series and the booster perspective?
Yeah, so if you remember back in the beginning of the pandemic, we had recommended that there needed to be a 14-day delay between any vaccine and COVID or COVID and any other vaccine. But as we live and grow, we learn more information and we know that is no longer necessary. And in fact, now the recommendation is that if you have not yet completed your primary series for the COVID vaccine and are due for your flu shot, you can get them simultaneously. And if you do qualify for a booster shot, you can get your flu shot and your booster shot at the same time. And I'll just share personally, I did that yesterday, and right now I'm only suffering from a sore arm in the arm that got my COVID shot. My flu shot seems to be doing pretty well, and frankly, I feel a little bit more comfortable than I did yesterday.
So separate arms, right? But same time.
We recommend separate arms. I do know that there are some locations around the state that are doing them in the same arm, but we typically do not do that when we're administering it.
Okay, thanks for that clarification. So, unfortunately, we're at the top of the hour. So we have included some tools for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists. I hope this hour has been a help to support you, your employees, and our communities to safely manage through this pandemic. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on October 7th, only 1 week from today. We are thinking that our audience has many questions in addition to a need for up-to-date information. Our theme for this session will be critically relevant information, answering everyone's questions. Dr. Jarvis, our physician leader for COVID-19 communications, Dr. Marnick, an immunologist from Hudson University with a passion for making complicated science understandable, and Yamaya St. Clair, a mental health workforce counselor, will join me for a roundtable discussion focused on our audience's questions, intent on addressing what's on everyone's mind. We will give you a brief update on hot topics, then launch into this roundtable discussion. Guaranteed, we will all learn a lot. We will send you the link for this session. We encourage you to share the invitation with your friends, colleagues, and others who might benefit from this information. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.